Hi everyone, how are you? I'm Galya. I'm on my road to RN. I'm going to talk about antipsychotic medicines in this first segment. So let's start with lithium. Lithium is a medicine mainly used for bipolar disorder, but it's also used to treat the migraines, depression, mania, anorexia, and alcohol dependence. So let's talk about the mechanism of action. It blocks the release of norepinephrine, okay, and serotonin, which we know are neurotransmitters, right? And then in turn, that increases the amount in the body, and it is if it's in the synapse longer, it works for longer, which is what we want it to do. And then also it affects movement of salt in and out of the cells. And since we know that salt and water always go together, then it also affects water if it affects salt. And if it affects salt and water, then we really need to keep an eye on the patient's, intake and output. And we need to have them drink at least 2,000 milliliters per day, but no more than 3,000 milliliters a day. So I know this can be confusing, but if you drink too much, it can cause hyponatremia, which can be dangerous. And if you drink too little, then it's going to cause hypernatremia, which we know, and it's dehydration, and that is that can be toxic with lithium. So the what do you call it? The therapeutic level is 0.5 to 1.2, and you have to assess that a lot. And so let's think about what would be prohibited if we don't want a lot of renal excretion, what would be prohibited, and what kind of drugs would be interacted. So diuretics were, of course, because it's the dehydration of sodium and water, and theophylline because it causes increased renal excretion, and so anything that releases too much water is not good when you're taking lithium. So also NSAIDs and ACE and ARBs you have to be careful with. And so also caffeine is prohibited because, as we know, caffeine is a diuretic. So that would go under the category of toxicity increases with diuretics. So we can look for changes in the EKG. We have a lot of times see thirst and polyuria in patients, including elevated white blood cells, which usually senses that there's an infection in the body. And you have to know toxicity because it's really dangerous. And they should come 8 to 12. Well, so it's first usually tested 8 to 12 hours after their first dose, and then 2 to 3 times per week for the first month, and then weekly, and then monthly. And as I said before, the therapeutic range is 0.5 to 1.2. So how would you know if it might be toxic? So your patient could present with confusion, lethargy, which is like, I don't really want to wake up, I'm lying in the bed. Slurred speech, increased reflex reaction. So if you do those reflexes on them and they are just kicking you in the face, then that's definitely a cause of concern. And then the treatment for this is hemodialysis. So yeah, so that's it about lithium. If you have any more questions, let me know. If you want the fact sheet that I put together, also let me know that too. Now we're going to go to atypical psychotics. So I'll just name a few. I'm going to focus mostly on the prototype, which is clozapine. So olanzapine, risperidone, quetiapine, ziprasidone, and ariprazole. So ariprazole is also called Abilify. You might have heard of that before. So these are oral medications, so pop and pills, right, to be metabolized by the liver. I know it's a huge surprise. And it's, again, for a huge surprise, it's excreted through the kidneys. So let's talk really quickly about the mechanism of action. So it blocks dopamine, serotonin, receptors in the brain, and it decreases the reticular activation system, which can cause us to be lethargic and tired. And that's one of these side effects that we will talk about later. So what does it treat? Schizophrenia, usually, and it also treats behavioral and psychotic symptoms of dementia. A good side about this is that it has fewer extrapyramidal side effects. Extrapyramidal side effects are those that are like Parkinson's disease, which we'll talk about in another segment. But it's like a lot of movement of your body that you don't want to happen. So it's involuntary movement. Okay, so benzodiazepines combined with clozapine can cause CNS depression, which makes sense because they're both working on CNS depression. So it increases the effect. And then clozapine with anticholinergic drugs will potentiate the action because it also has an anticholinergic effect. And then clozapine with digoxin and heparin. We know with digoxin we have to be very, very careful about the therapeutic range. And the clozapine can increase the digoxin and heparin risk of toxicity. So we want to be really, really careful when we're using these two. And then tardive dyskinesia, it can occur with prolonged use, right? Which we talked about a little bit before. And it can be treated with Benadryl. But yeah. And then clozapine with phenytoin decreases clozapine levels. Phenytoin is a medication for seizures and spasticity. And okay, so then let's go to the typical antipsychotics. This one is haloperidol, or also called Haldol. And the mechanism of action is it blocks postsynaptic dopamine receptors, and it acts on the chemoreceptors in the medulla. So it has, it's said to have some kind of antiemetic effect, meaning it makes you less nauseated, and it makes you less, throwing up. It takes away the control. Your body doesn't have to bomb it, basically, is what it is. And it's used for schizophrenia also. It's also used to calm anxious and agitated patients and improve the thought processes. So a lot of times you hear that in mania or in bipolar disorder or in schizophrenia or in those kind of things, you have just thoughts like 90 miles per hour in your brain. So it's proven to improve those thought processes. And because of the lower amount of dopamine, it alleviates delusions and hallucinations. So now we know that if there's a high level of dopamine, it can cause delusions and hallucinations. Okay, so nursing implications. If you're a nurse, you're going to need to know this, obviously. We encourage the patient to take this with a full glass of water or milk, whatever they want. And we have to monitor for hypotension and definitely assess for urinary retention and monitor the potassium. And then neuroleptic malignant syndrome is a very, very serious but rare complication. And we need to assess the temperature of the patient. And then we have to monitor the patient for Parkinson's-like syndromes. So I was talking about tardive dyskinesia earlier, and that's what we have to monitor them for. It can be treated with Benadryl, once again. Okay, so patient education. What would you teach the patient? So the drug is never stopped abruptly, which is like with most drugs. So if the question ever says, like, should the drug be stopped abruptly? It's usually no, it shouldn't. and they should take the meds at night, and avoid alcohol and caffeinated beverages, as we said. And then there is a risk of photosensitivity, so make sure to remind them they should be careful of sunlight, heat, and tanning beds, which everyone should be careful with. But like if you have this medicine, haloperidol, you're even more susceptible to photosensitivity. Okay, so let's talk about stimulants. So stimulants are medications that block the reuptake of dopamine or inhibit MAO. So it increases the levels of dopamine and norepinephrine. So just want you to note that when you're blocking the reuptake of something, you're increasing the blood levels. So if we're blocking the reuptake of dopamine, that means we're going to have more dopamine in our blood. So some medications that are stimulants are dextroamphetamine, methylphenidate, and mixed amphetamine salts. Okay, so drug interactions. Since one of the mechanisms of action is to inhibit the MAO, we don't use if there was an MAO inhibitor was within 2 weeks of it. And then for methylphenidate, which is the second one I said, it increases the effects of tricyclic antidepressants, which we don't have to go far into now. Just know that it increases the effects of them. And it also increases the effects of warfarin and seizure medications. And it may decrease growth. So you would want to monitor for height and weight. Okay, so benzodiazepines. They're used for a few different things. They're seizure medicines, anti-anxiety medicines, sedative medicines, and muscle relaxants. So how it moves in the body, pharmacokinetics, okay? It's absorbed rapidly, and it's metabolized in the, wait for it, it's a huge surprise, liver. And then you pee it out. So the mechanism of action is to stimulate the GABA and aminobutyric acid receptors in the ascending reticular activating system. So the GABA receptors are inhibitory receptors. So this is what makes us this is what sedates us. This is what gets us tired. Some general and local anesthetics also activate the GABA receptors. So yeah. And then you should not take it during pregnancy because it crosses the placenta. And it also comes out in breast milk, so don't take it while you're breastfeeding. So adverse reactions. So let's think about what we're doing. We're depressing the central nervous system. So what would we have as side effects if we're depressing the central nervous system? So I want to close your eyes, okay? Close your eyes and think about it. Did you think about it? Okay. I'm going to read them off, check off which ones you got right. Drowsiness, confusion, ataxia, weakness, dizziness, nystagmus, vertigo, fainting, unclear words, headache, tremor, and glassy-eyed appearance. Okay, stop. Which ones did you get right? Glassy-eyed appearance is one that's always hard to remember, and because that is not always doesn't always have to do with doesn't always have to do with the CNS nervous system, but it is a side effect of the medication, the stimulant medication. The benzodiazepines, excuse me. Lastly, we're going to talk about barbiturates. The prototype for this is phenobarbital. And it's used for reduced effect. It's reduced effects with rifampin, which is an antibiotic. And it's used for seizures, but it's used less now. And when you're taking corticosteroids, cimetidine, and phenytoin, you have an increased metabolism with it. So The dose should be between 60 and 80 milligrams a day to achieve a serum level of 10 to 40 micrograms per milliliter. So if you see the dose being way outside of that category, the 60 to 80, you need to make sure that that is the correct dose, because normally it doesn't go normally it doesn't go much lower than 60 or like much higher than 80. So that's it for antipsychotics and just like CNS, whatever. I understand that stimulants aren't antipsychotics, but we put that in that category for this purpose. If you have any questions, feel free to email me. Have a good day.